इसे ना इस पीछे लगा दो, इसके 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 आगे लगा, इसे पीछे। तुम्हारा कवर हो गया ना? बस करना, उठा लिया। चलो छोड़ दो। बस इसमें रखते हैं, इसमें रखते हैं।
आप बताओ, आप 27 को जा रहे हो? 27 को एशिया होते हुए जाओगे? 27 को हमारी सेंट्रल काउंसिल है।
अच्छा,
तो आप कहीं पे
नहीं हम 26 की लाइफ को।
अच्छा, नहीं होते ये गाना बहुत ही
आप 19 को आएगा ना?
तो देख जाऊंगा।
हाँ
बिना भी ले जाए बट मैं तो देख जाऊंगा, क्योंकि मेरे को ना बहुत ज़्यादा अभी आज मेरे को ईयर एंड हो रहा है, तो लॉट ऑफ प्रेशर इज देयर। वेलकम। और दूसरा है कि मैं लेट नाइट नहीं कर रहा हूँ बिल्कुल भी। मालूम है मैं लेट नाइट नहीं कर रहा हूँ।
हेलो सर, उठा लीजिए, लिंक उठा लीजिए।
2 बार वो किया था,
भेज दिया
बीक्यू स्कैन
सर। आप इंस्टा लाइव का आपके पास है ना वो?
अभी नया डन करते।
अच्छा, मैं वैसे भेजता हूँ मैं, बट
सीधे चढ़ा तो मेरे को 5 मिनट रुकना पड़ेगा।
तो यू आर टेकिंग वाटर ना?
मैं डेली कटल पे आ गया हूँ।
ठीक है सर। अच्छा,
ठीक है ठीक है।
नहीं नहीं कंटेंट बेटी।
दैट्स गुड।
तो मुझे कुछ आ रहा है?
हाँ जी, आ रहे हैं।
आते रहते हैं। क्लियर कागज देते हैं?
यस सर।
तुम बैच के हो तो
I am actually 74 I joined sir.
वो लिंक उठा के मेल करना मेरा प्लीज, थोड़ा अर्जेंट है।
आप कौन से बैच के? 7.
But I am from
Right.
I joined 75.
नमस्कार सर।
Hello, sir. Yeah. Long time. Long time.
क्या चल?
First class.
So on a long holiday?
Holiday.
कितने दिन आता छुट्टी?
जा रहे 26 में जा रहे हैं वापस।
अच्छा। बैंकों से करते जाओगे ग्लोबल बैंकों वीक
हाँ वो 19th को भी है ना
उन्हीं भी होते
हाँ right.
तो वही रूटीन वाला वही प्रोसीजर है समझे?
हाँ जी सर वही प्रोसीजर।
तो डॉक्टर साहब क्या फॉर्मेट है
सर तक अभी ना एक IMA का वेबकास्ट है इस पे इंस्टा लाइवली पे, वो मुझे आप व्हाट्सअप कर देंगे प्लीज़ थोड़ा जेंटली।
जीपी
अभी कर
more for मतलब basically talk about breast cancer and later on touch about pain management. We have one full hour, so we have enough time to do that. Okay.
ये अभी तक के रजिस्टर्ड डेलीगेट्स विद फोन नंबर्स एंड मेल एड्रेस मेल अभी ये पेपर आपके पास फैक्चर भी
मुझे बोलना
मैं
पड़ेगा।
आपको बोल दूँ अभी है ना टाइम 5 मिनट
बस इसे रखो राजेश।
7 मिनट
मेरे को फोन करा, ईमेल करा के रखा है। कितने लोग हैं?
आज से कम ही है बिल्कुल आज से कम ही है
ठीक है। तो क्या क्या किया उसके बाद? Did your MBBS,
MBBS then
MC, then
and I did pulmonary medicine
संजय जो आपने मुझे लिस्ट दी है ना
pulmonary medicine for the chest
वो एक लिस्ट जो है मेल कर दो डॉक्टर KK अग्रवाल की
chest MD chest
MBBS.
then I went to USA
Hmm.
then I did my first my internship
Hmm.
I'm sorry my residency from Georgetown
या पानी है लोड हटा
I
दो
did my
Throw
fellowship
down.
from Johns Hopkins
Hmm.
fellowship from Johns Hopkins
Fellowship in?
Johns Hopkins in hematology oncology
Hmm.
मैं हस्बैंड बोल
I've
रहा
been in practice since 1992.
1990 से practice में।
Correct.
नहीं मेरे को अभी कुछ बात करनी है और बेटी होता डिनर सेट कॉफी माल कितने छः बहुत खाना माल 507 के लिए
टाइम मत लगाओ ना।
चला है राजेश।
टाइम मत लगाओ, कल बोल
मैं
दो।
आज कल दोपहर तक आपको
क्या दिखा रहे हो लाइट?
इसमें लगवा दो। Anything which is non-perishable. ठीक है।
आप कल से से करना है ना
ऐसे नहीं होना चाहिए। नहीं, ठीक ही बोला मैंने।
हेलो
This will be only when he comes.
ठीक है सर दे रहा हूँ
ही कम
Perishable, otherwise non-perishable. So,
नहीं तो हमने जो कोल्ड
हाँ, हाँ, बिल्कुल।
now cans वगैरह जो है, cans है, beer can है, इसका can है, soda है, सब चीज़ें हैं।
उसका आंसर 2 दिन पहले रखा
नहीं, वो तो है ना, वो जो चीज़
हाँ।
non-perishable होता है, तो इसका वाला
लाइफ होती है 3 दिन पहले
Nicola, आप email पर request करते थे। That I told them every 3 months somebody goes and places it. It's going to be there every month now.
फ्रूट जूस
I'll make sure.
नमकीन तो अभी नहीं चाहिए
But आज इसका भी बहुत अच्छी है ना?
वो तो 25 के लिए
हाँ, ठीक है। ये रख दो वहाँ पे। ये रख दो वहाँ पे, बेडरूम में। चलो साफ करें, कितना टाइम है?
अभी 3 मिनट है
3 मिनट है।
साथ अब आया नहीं अभी ठीक ठीक
हाँ सर। नहीं जरूरत नहीं।
You're staying in Delhi only?
Hi.
Also possible.
Thank you.
यूएस में कितने हो?
हाँ जी।
और ये प्रूफ करना है, पता एंड का प्रोग्राम, इसको गाना गाना नहीं आता। या तो ये प्रूफ करेगा ऑडियंस के सामने कि आज वेबकास्ट में
ऐसे लोग हैं, कहीं पर भी कितना भी
मैंने क्या
कैसे
बोला,
भी
before we finish, either he proves that he knows how to sing, otherwise he has to admit कि मेरे को नहीं आता।
he will prove that it's
बस ठीक है, तो तुम्हारा काम है।
he will not let
Keep that 5 minutes for that.
Washington DC के suburbs, बिल्कुल Maryland में. It's about 5-6 miles north of Washington DC. तो बिल्कुल.
Yeah, I've been there.
हाँ जी.
I've been. My daughter was in New York for many years. Now she has moved to Mississippi.
अच्छा.
She is assistant professor in University College. there.
अच्छा.
Correct, sir?
My
Yes,
son is
yes, sorry.
gastroenterologist.
Greetings from Digital Team IMA. I'm Dr. K K Aggarwal, its Secretary General, and welcome to our weekly show. And every Thursday, as you know, we do a webcast for 1 hour duration. And the statistics of the last 6 months have shown that 1,500 to 2,000 doctors participate in this webcast on a weekly basis. Every week we touch up a subject. Today we have an international visitor, though he is our own, because he graduated from Maulana Azad Medical College. But over the last 2 decades, he has been practicing in US. He is Dr. Sajeev Anand, who is a diplomat, American Board of Hematology and Oncology. Did his MBBS from Maulana Azad Medical College. He was joining was 1974 batch. And then he did his MD in chest medicine at Patel Chest Institute at New Delhi. And then he shifted to US for his residency and later fellowship at Johns Hopkins on hemato-oncology. And for the last, say 1990, he is practicing as a hemato-oncologist. And we thought of, he is visiting India, and whenever any person of eminence visits India, we try to bring in their expertise to the medical profession. And not only that, he is a hemato-oncologist, he is also an expert in pain management. So we are going to explore initially what every GP or a practitioner should know about breast cancer, and then we will touch some aspects of hemato-oncology which are not there in India or not there in India in every facility, and then we'll touch a little bit on pain management. And then we will explore, because we have heard that Sajeev is a very good singer. We'd like to explore whether this is true or not with that. So Sajeev, why did you thought of hemato-oncology?
During my MD chest, Patel chest, my thesis was on lung cancer, which actually really got me into oncology. That was my, that's how my first interest, that's how my interest started there. And, you said that I'm a singer, that requires a lot of compassion, a lot of emotions, and that's that's a very integral part of practicing hematology oncology. And I didn't.
Have you ever thought of music therapy for cancer therapy?
Yeah, we do that all the time, actually.
Oh.
Yeah, sure.
And you have any specific words, any specific, see, music can be fast and slow. Slower music will lead to parasympathetic mode.
Any kind of music, music is a healer, and certainly, it puts your mind at ease, and by putting mind at ease, it boosts your immunity, actually, help.
So are you aware that whenever you have a physical pain, the
Yes.
body will only produce a vowel?
Yes.
Ah, E, O, A, ouch.
Yes.
And if you chant a vowel, it produces interleukin 2. Okay? And whenever you weep, you will weep a nasal consonant. Ma, na, ga, na, na. Na, ga, these are weeping sounds. sounds.
Mm-hmm.
And weeping sound produces delta activity in the EEG,
Mm-hmm.
and it produces tranquilizers.
Mm-hmm.
Therefore, chanting of a vowel and the chanting of a nasal consonant together
Mm-hmm.
will produce aspirin and a benzodiazepine combination. So
Correct,
therefore,
yes.
it is going to relax the person.
Absolutely.
Therefore, all our mantra, all our religions, all whatever is, all healing sounds are a combination of a vowel
Mhm.
and a nasal consonant.
Yes.
So therefore, music has to work.
Absolutely. Absolutely. Yes.
Music has to work.
Yeah. Yeah. Sure. It certainly. I mean, it relaxes the brain. Releases. Certain endorphins. Get you relaxed, and certainly.
And then from lung cancer, how did you go to breast cancer as your expertise?
Oh no, I mean, I practice general oncology, so I see all
all of them.
patients. Yeah, I see lung, breast.
Anything latest in lung cancer? Because lung cancers are increasing in our country. There was a time when it was rare, but
Mhm.
now, if I say in men, lung cancer is slowly becoming number one cancer.
Mm-hmm. Yeah, in lung cancer, some of the most important discoveries have been targeted treatments. Basically, these are not chemotherapy drugs. These are specifically targeted to the molecules, basically, which help cancer to grow. There are substances like certain enzymes which actually are called angiogenesis growth factors. So we have now drugs which can specifically inhibit those angiogenesis growth factors and cut the blood supply of the tumor in the lung.
I saw one, I don't know which part of the US, there was a study where they've taken cancer cells of the lungs. They've taken, before I forget, all our fellow doctors, please note down the number 9810118256. This is the phone number you can call or SMS. You can also SMS 98110902006. You can also go to the website of www.emedinexus.com. In this website, it's something like a Facebook. You can see the live transmission and you can put your comments and you can answer, put your questions and you can answer it directly with that. So what I was talking about, when I saw that in the US, they've taken lung cancer cells and they were irradiating them again and again. And once they have done a cycle, they were re-injecting them to the person to find good results. Any such?
Well, this could be part of boosting your T cell immunity actually, and fight against lung cancer. But aside from that, now we have drugs called epidermal growth factor receptor antagonists. Epidermal growth factor receptor (EGFR) basically is involved in the proliferative activity of lung cancer. So we are actually now gradually moving away from chemotherapy, which has a lot of different side effects, to the drugs which are very specifically inhibit those. Correct. So these are called targeted therapies, and that's the latest.
How costly they are in the US? And how cheap they are in India?
Well, they are pretty expensive, right now. But
Available in India?
I'm sure they. I'm sure they are. Yes, I'm sure they are.
Go back to breast cancer.
So while we talk about the topic today, breast cancer, Dr. K K has said that it is very common and late diagnosed. When we are talking to GPs of the country, we should
Right.
And except for physical examination, there are any markers to say that this patient is going to develop cancer, breast cancer especially? Family history is there, and when do you start screening, and what age in the cancer parents and non-cancer parents?
Correct. Well, let's first talk about what is the incidence, and I looked in the data from India actually, and seems like in India they say 100,000 cases of breast cancer diagnosed each year.
Every day.
And all of that, and this constitutes about 20% of all cancer diagnosed in women. This is the second most common cause of cancer in women. The first being cervical cancer, it's about 38%.
But in urban areas, now breast cancer is number one. In metros, now breast cancer is number one.
you know, now if I compare that with the statistics from the United States, basically, where 300,000 breast cancer diagnosed annually, you know, it seems very unlikely that these statistics from India represent
Will
true.
be correct, yeah.
Yes.
Because,
Yeah.
US population is much less than India.
Correct. Now, where we stand with breast cancer, at least in a developed country like the United States, out of those 300,000 cases, 83% breast cancers are not cured. Only 17% of patients die from breast cancer. So, you know, I don't know how the statistics are in India, but you know, that should be the state of art everywhere. That, you know, out of all the breast cancer diagnosed, we should be able to save 83%.
In terms of breast cancer, what is the definition of cure? Is it 5 years or is it?
Cure means cure, basically.
Cure.
I mean, you know, and
Normally, in cancer cure, you talk about 5 years survival rate, but here you're talking about cure.
cure, yes.
Okay.
Correct, yes. And this is related to the annual incidence of breast cancer versus annual deaths from breast cancer. If you take a ratio of that,
That's right. That's
so that
Any
comes.
reason why breast cancers are increasing in India?
Yes, I think first of all, pollution. Incidence of smoking is increasing in India as well, basically, and so those are some of the issues basically. And I think the other issue could be, you know, as in, you know, we in India are getting more and more affluent, these things are getting diagnosed more and more basically, and so, you know, so we are getting.
Breastfeeding has any role to play?
See,
Now-
diagnosis will be more for early diagnosis.
Correct, yes.
Cancer incidence will not be, say, otherwise what happens? Initially, more advanced cases will be diagnosed, now early cases are being diagnosed.
Correct.
But there is definitely an increased trend in the increase in the numbers.
Correct, yeah.
There has to be some
Urbanization, yes. Urbanization
Maybe
certainly.
reporting gets better, you know. More
Yeah.
people are going to
Yeah.
hospitals and
See,
colleges.
what I'm
and
trying
they're
to
able
say,
to tell.
let us see when we were in MBBS, we used to see so many cases.
Well,
Maybe
we used to see our fair share of breast cancer patients, yeah. But certainly
More
urbanization, you know, more better diagnostic tools,
Better
basically, you know, I mean,
So we
and
were
better
talking
reporting
about
actually.
any markers?
Now,
Any
yes,
markers?
absolutely, I was coming to that. So, yes, genetic markers are there, you know, these are called BRCA1 and BRCA2 mutations, basically.
Mhm.
And they have been associated with a significant amount of increase in the rate of both breast cancer as well as the ovarian cancer. So suppose if there's a patient, you know, has a very strong family history, you know, at least two say relatives from the same side of the family, you know,
Yeah.
mother,
Yeah.
sister. So in that instance, you know, or somebody diagnosed at an early age, very early age, 30, 40, 45 years, you know, we recommend checking that these mutations called BRCA1 and BRCA2 mutations. And if they are positive,
At what age would you prescribe them?
typically what we do is, you know, if there's a strong family history, as I said, you know, I think that makes a case of doing a, you know, BRCA1, BRCA2 mutation. Plus also somebody diagnosed at a young age. In United States, typically, you know, if somebody's diagnosed before 45, you know, even if they do not have a family history, we recommend doing these BRCA1 and BRCA2 mutations. Yeah.
And if they're positive?
And if they, well, yeah. So before we do those mutations, these patients must have genetic counseling, basically, you know, because now, you know, if they are positive, then, you know, we are talking about having a risk of development of breast cancer over life to be about 50%. Developing a risk of ovarian cancer to be up to 85%.
Okay.
So these patients then, you know, have to be counseled, and, you know, and certain recommendations are to be made in regards to either doing a bilateral mastectomy for them, and once they are done through the reproductive age, even removing, you know, doing oophorectomy for these patients. Yeah. So when you're giving those kind of recommendations, you know, you must first do a genetic counseling with the patient, before we even check these BRCA mutations.
Oh, that's great.
Any other, say for example, now let's come back to the screening of breast
Yes.
cancer and screening of ovarian cancer.
Yes, yes.
What are the current recommendations?
Now the
And
current
the recommendations why Foxy in India slightly.
Right. So let's first talk about how what are the screening recommendations for breast cancer. I think the screening for every woman should start at an early age, basically. I would, the recommendations are, after the age of 20, a woman should, do a self-breast examination during the mid-cycle. And it's also recommended that do, once every other year, exam by a physician. And if there's a family history of breast cancer, then it is recommended that these women have their first mammogram to be done at the age of 30.
Okay.
And if there's no family history, then every woman should have a mammogram done at the age of 40, and then yearly thereafter. Some people say you can get it every other year, but I think if you look at the NCCN guidelines, they recommend do once a year.
So the message will be that if you have a family history, first
Yes.
mammo at 30,
Yes.
and if you have no family history, first mammo at 40, then leave it to the doctor to decide when next.
No, not leave it to the doctor.
No. See, say a person may not remember so many things. First mammo 30, then ask your doctor when do I need to repeat.
Correct.
His
Yes.
doctor needs to be correct because
Correct.
public can't remember so many things.
Very true. But if doctor forgets, the public has to
So we should
remember
prosecute it.
that they have to get an annual mammogram after the age of 40.
Yeah, that's right. We were talking about breastfeeding, role of breastfeeding.
Yes, yeah.
And-
Breastfeeding actually prevents breast cancer. So let's talk about what are the risk
So
factors for
you
breast
say
cancer.
that because there is lesser breastfeeding nowadays in the country, in India also, the
That-
may be
that-
increasing.
That could be contributing. The other things early menarche, late menopause, say for example, and late pregnancies, also, because because during late pregnancies, women get fibrocystic disease of breast, which is one of the risk factors. So one of the things will be, women, who used to get married at 12 and have a child that's 14 or 15 or 16 years of age, basically, they would get protected from development of breast cancer. Versus if the woman gets pregnant at the age of 35.
Yeah.
Because now at the age of 35 they already have fibrocystic disease of the breast, which is basically hyperplasia of some of these glands, and the ducts.
Mhm.
On top of that, you give them estrogen stimulation, significant amount of estrogen stimulation from pregnancy, and they develop breast cancer.
Dr. Rajinder Kaul is asking, is there any link of smoking with breast cancer?
Smoking and drinking, both.
Smoking.
Absolutely.
Active as well as passive.
Absolutely.
And is there any link in terms of amount of alcohol or drink?
One of these studies, these days, say 2 drinks of wine are okay, but there was a study recently from Europe which showed even 2 drinks increase the risk of developing breast cancer.
2 drinks in women.
Yes.
The recommendation is only 1 drink.
Yeah. Well, 1 or 2 drinks. So in a small amount of
It is not a recommendation.
No, in women the dose is 50% less than men. If two are safe in men, then women in any way 1 is safe. More than 1 is.
Actually, as far as the breast cancer is concerned, none of the drinking is safe for women. Basically, even small amounts of drink can cause a small amount of risk in breast cancer. Basically.
And what about obesity?
Obesity, yes, calorie cause cancer. Calories cause cancer. Breast cancer, the highest incidence in Sweden, where these women eat a lot of fat, So per capita increase in the amount of fat actually causes increase in breast cancer, basically. Absolutely. Obesity is certainly smoking, obesity, and as I said, fibrocystic disease, late pregnancy, genetic mutations, family history. So these are the basic risk factors of breast cancer. Age, very important.
Before I proceed further, again, just to show you that you can see the imatinaccess.com, the live webcast is going on, and you can ask your questions on the lines of Facebook, and every minute I'm updating what is being spoken, so you can also interact directly with us with your questions directly on the website, and which you can open it in your mobile. If you have an Android mobile, you should be able to do, and you can see the live webcast is being telecast. Good.
Yeah. And we were talking about calories and obesity. So it may be one of the reasons why all over the world the number
See,
of
the more
incidents is
the more
increasing.
affluent society
So one more
becomes,
question.
the increased risk of breast
Two
cancer.
more questions
Yeah,
have come
yeah.
from Dr. Jaswant Oshan. What are the various markers for the prognosis of breast cancer?
Well, markers, there are markers which have been developed after breast cancer is diagnosed. And these markers, one of them is CA27-29, another one is CA15-3, and the regular CEA, these markers can be used. But they are not to be used for screening purpose, basically. They're only to be used once the breast cancer has been diagnosed, patient has been treated, or in the process of being treated, and then you can measure the markers basically to see what kind of response the patient is having. And also you can, if somebody's in remission after breast cancer, after all the chemotherapy and everything, you can measure these markers, to just check and see if they stay negative, then you're okay.
Dr.
But,
Rajinder
they're
Kaur is
not-
asking, is there any correlation of alcohol with ovarian cancer?
Not to my knowledge. No.
Okay.
Yeah, ovarian cancer is a different ball game, and I don't think that I remember any correlation with alcoholism and ovarian cancer.
So if you have
But certainly, if somebody has history of breast
undergone-
cancer, the risk of ovarian cancer goes twice.
Okay. I thought if you have undergone primary mastectomy as a precaution, then you can take a lot of alcohol. Not that way.
Yeah.
What about men?
Alcohol causes about 38 different kinds of cancer, so I would not recommend drinking alcohol to anybody.
Do you drink?
I know, I don't.
Good.
That's why you recommend no alcohol. What about men? Men breast cancer.
Yeah, male breast cancer is very rare, about 1 to 3% of all breast cancers in general, and typically is associated with BRCA, those BRCA1 and BRCA2 mutations. Now, mind you, these mutations not only cause cancer in females, basically, but they're also, they can also cause cancer, a male breast cancer. In males, if those mutations are positive, they can also cause colon as well as prostate cancer. So men who have these mutations, should have, an annual mammogram basically to rule out, any lesions, which could cause, and certainly they need to have a PSA testing once a year, and screening colonoscopy,
That's a
recommendations.
routine,
Correct.
I think.
Exactly, yes,
Colonoscopy
yeah.
is a routine.
Very
What is the incidence of colon cancer in US?
The incidence of colon cancer, basically, I think we detect about 170,000 colon cancers every year, basically. So it's a little bit less than, yeah, that's.
So let's enumerate 5-6 breast prevention tips for a GP.
Okay, so first of all, we discussed, what are the risk factors for breast cancer, and physicians, should talk these things to patients, basically, talk about, say, about.
So if I'm going to prevent heart disease, diabetes, blood pressure, and osteoporosis, will also take care of breast cancer prevention? Or there is specific?
No. They're very, breast cancer,
What do I need to do for I'm not talking about the family history.
So we talked
I'm
about.
talking about in general population with no family history of breast
Correct.
cancer.
So we talked about doing a self-breast examination. We talked about a mammogram. Those are the two main things. We must screen.
That is for early diagnosis, prevention.
Okay.
I'm talking
No.
about exercise, diet. What are the prevention things which
Okay. Yes. Okay.
breastfeeding,
So-
early marriage, something like that?
Sure. And those things are there basically. One should get married at the right age. Get children at the right age. Basically, exercise, walking. Walking actually certainly prevents breast cancer. Not running, not lifting weights. Walking. Walking
Okay.
seems to prevent breast cancer. Basically.
So,
Yeah.
in a way, you're
Plus-
talking about calorie
Correct.
is cancer.
Any what's new?
Plus
in-
also, if somebody does have history of, say for example, fibrocystic disease, basically, or somebody has a biopsy which has shown, say, evidence of some dysplasia, what we call as atypical intraductal hyperplasia.
Mhm.
These women should go, and their risk actually becomes twice the normal population. To bring it back to the normal level, we recommend that they take tamoxifen.
Just
for
give me a
5
simple
years.
layout plan for a doctor to understand.
Right.
A female comes to you with a breast cancer positive.
I'm sorry.
She is breast cancer suspect.
Okay.
There is a mass. You have done, say, now you will go for a FLSC or a trooper biopsy or open biopsy.
Okay. So let's talk about that.
Yeah.
So,
So I'm going stepwise. A
Yes.
female comes to you with a lump.
correct.
What
A
next?
female comes with lump, basically, you examine the patient's lump, let's see how old the patient is. Less than 30, more than 30. Generally, and whether the patient has family history or not. If the lump appears to be like a fibroadenoma, free removal in the breast, basically, no family history, not increasing in size, perhaps, you can just watch it every 3 or 4 months or so just to make sure that the size is stable.
Without even FNSC.
Well, as we said, this is, somebody is less than 30. Now, if somebody is more than 30, has, and the lump feels suspicious, is firm to hard in consistency, in that case, you got to have basically a mammogram and a sonogram first. Now, depending upon what mammogram shows, if the suspicion on mammogram is low, and the sonogram is also, not suspicious for malignancy, basically, no speculated lesion, then we can perhaps watch it, basically. On the other hand, if the mammogram is suspicious, then we got to have a core biopsy to be taken of the lesion.
Why I'm asking this question again is that core biopsy is better than needle biopsy, than the FLSC.
Yeah. Well, basically, core biopsy will give you a little bit more tissue, and certainly, it will.
Okay. Now core biopsy is done. It is positive.
Right.
Okay.
Right.
Now should I go for a PET scan or not?
No. So let's say the core biopsy has come back positive. Then the question is, what kind of breast cancer it is. As everybody knows, in breast, we have lobules, which produce milk, and the ducts which transfer milk. So cancer can happen either inside the ducts or inside the lobules, basically. And from the ducts, it can extend outside into the fat or the breast parenchyma, and same thing can happen from the lobule. So this way, it can be either intraductal, inside the duct, or intralobular, or it could be invasive ductal when it's outside the ducts, or invasive lobular. Now then the management certainly depends upon whether it's intraductal, which is called non-invasive, or outside the duct, which is called invasive. Now, if it is inside the ducts, basically, one can do a simple, what we call as lumpectomy.
Conservation. Breast
Conservation,
conservation.
yes.
So
And-
if it is intraductal,
Yes.
one can offer
Just a simple lumpectomy.
breast conservation surgery.
Yes, breast conservation surgery. And then, depending upon whether it's intraductal or intralobular, they have different, approaches, basically. Typically, if somebody is intraductal carcinoma and you remove the lump and all the margins are clear, clarity of margins is extremely important.
Okay.
And what that means is that you should have at least 1 centimeter, from all sides. There has been evidence to suggest that once you have removed the lump, radiation post radiation therapy will increase the survival. So looking at the National Comprehensive Network guidelines, which most of oncologists follow, it is recommended that all patients, after having a lumpectomy for intraductal carcinoma should undergo, radiation treatment. Basically.
When is the role of chemo?
Now, certainly, if the tumor is intraductal or intralobular, chemotherapy is not indicated because the tumor was still in the ducts, and it had not infiltrated, it had not had chance to spread, basically. Now, if the tumor has, say, gone outside the duct, so it has become invasive ductal or invasive lobular, then the role of chemotherapy comes. If the tumor is, if the tumor is still small, so let's say, less than 5 millimeter in size, these patients, typically will not require any chemotherapy, and what you can do is you just do a lumpectomy and do a sentinel node biopsy in those patients, which is very important. Sentinel node biopsy, in which you can actually biopsy one of the lymph nodes, which is just adjacent to the tumor, and if that is positive, basically,
It's invasive.
yeah, invasive is already there, but if it's positive, but say only about 1 or 2 lymph nodes are positive, you don't have to actually remove all the lymphs from the axilla, because that used to cause a big, huge lymphedema, which actually is very, very, and woman has to live with that for the rest of the life.
Yeah.
So it is very important that one must do a sentinel node biopsy, and if the sentinel node biopsy is negative cancer, there's no need to touch and remove any lymph nodes from the axilla.
Okay.
In that case, what you can do is, now if the tumor is less than 5 millimeter in size, basically, all you have to do is just give patient radiation, and no need for chemotherapy after lumpectomy, and the chance of cure is going to be very high.
So Dr. Rajendra Paul is saying lumpectomy has to be done after keeping prognosis in mind. Please discuss.
Yes, lumpectomy must be done keeping the prognosis. Now, what determines prognosis? Prognosis actually is determined by the hormone receptor status. So once we have the lumpectomy specimen, pathologists test, do immunohistochemical stains on this to check for 3 things: estrogen receptors, progesterone receptors, and HER2 receptors, which is human growth factor receptor 2, HER2, which is extremely, extremely important and a very bad prognostic marker for breast cancer patients, basically. And if it is positive, HER2 is positive, these patients have to be treated in an entirely different way, basically.
He says that why breast cancer in India is more common in Parsi community.
I think, yeah, very true. I think this is quite true. It could be because they might be marrying late, basically, they might be having late children, or they might be having certain genetic abnormalities, which I discussed, but he's very correct. It's more common in Parsis, yes.
Okay, and maybe some diet or something they are taking more.
Possibly,
Yeah. So we continue there.
Yeah.
What
So basically, now, as far as let's come back to first introductory, basically. When you check these things, and now if the estrogen receptor is positive in these patients, after you have done the radiation, these patients should be given tamoxifen. Tamoxifen, as we know, is anti-estrogenic drug, basically, and it basically blocks the receptors of breast cancer cells and does not allow the estrogens to attach to those receptors which they need for their growth, basically. So for intraductal tumors, only estrogen check is necessary, not HER2 because right now we do not have any evidence that will cause any, impart anything to the prognosis. But when somebody has infiltrating carcinoma, then the role of HER2 and estrogen progesterone receptors become very important. In that situation, then we must know what the stage of the disease is, basically, because that totally determines what should be the next step. And stage basically of the breast cancer is primarily determined by 3 things: P, N, and M. Tumor, what's the size of the tumor?
Yeah.
What's the lymph node status? Are the lymph nodes involved? And are there any metastases anywhere else, basically?
So Sanjeev, I'm going to divert slightly. when we talk about chemotherapy in India
Yes.
or radiotherapy in India, we have very limited places where chemo and radiation therapies are available. And I was looking for a list of hemato-oncologists and oncologists. I don't think so. We have more than 1,500 or 2,000 in the country. Okay, the need is in lakhs. Even breast cancer we are talking about is alone breast cancer alone is.
Yeah.
So
You know, it will be very.
therefore 2,000 hemato-oncologists cannot cover.
True.
Okay. So therefore MD medicine, MD physician has to pitch in.
Absolutely, yes.
MD physician has to pitch in. I know of a oncologist in India who is creating a chain. He is creating a chain of physicians in the country, and he says, you send me the slide, send me this, I'll send you a protocol, and I'll help you out in delivering the chemotherapy. I'm not talking about only breast cancer, I'm talking about as a general. How can, in India, a set of oncologists, hemato-oncologists, okay, 5, 6, 7, 8, 9, 10 of them, why can't we come out with a website where there are standard protocols written? Okay, say for example, breast cancer, and then it is written is that if you send your breast cancer slide for an opinion to hemato-oncologist, he says yes, and he says now follow protocol B. Suppose in breast there are 7 protocols written in the webcast, in the website. He can guide the physician. He says, I've seen the slide, I've seen the staging, everything is being done. Now blindly follow B and come back to me if 1, 2, 3, 4, 5. If this happens, come back to me, otherwise you follow this thing. Why can't it be done in India?
We can absolutely do that. This is exactly what people do in Canada. You know, I mean, internists are doing chemotherapies there, basically.
No, I'm
Internists are
talking
doing
about it, as on today, standard protocols
Right.
are not available to a physician or
They are available. You just have to know where they are. You know,
Okay.
NCCN guidelines, you know, you just type NCCN.
No. See, I'm talking about, see, it has to be a ready-made protocol.
They are
It has
ready-made
to be
protocols.
written clearly with how to give it. See, those are slightly, so I'm
So
talking
you're
about
talking about the
guide-
logistics of how to administer chemotherapy.
everything.
Yeah.
Everything, including, and I'm talking about whatever a guideline for nursing and a doctor together, combined together into a protocol.
Even those are written everywhere, basically. So the guidelines are not only written for the physicians, and anybody can go on National Comprehensive Cancer Network, NCCN guidelines. They can register a login and become members of that. It's free of charge, and then you can exactly
You're
look.
talking about NCC?
NCCN, National Comprehensive Cancer Network guidelines, and they actually have tables for everything.
Okay.
They have tables for everything, what's the size of the lump, what's the...
As good as your experience.
Okay, I mean, we have answered this, but the question has come again. In such cases who are at high risk, are we talking about lumpectomy, breast removal? Does lumpectomy and oophorectomy make sense?
Absolutely, it does. We all know, that famous actress in United States, she had, her mother had ovarian cancer.
Yeah, she underwent all these things.
Yeah.
So
Brad Pitt's wife.
In prostate cancer,
Yes.
we always say remove the testis.
Yes. No,
Okay.
not always, but yeah, in a lot of times.
A lot of times. And therefore we are talking about in breast cancer, if you don't need the ovaries, remove them.
No, not necessarily.
Well.
Basically, because ovarian ablation can be if it really needs to be done, because in lots of instances, in majority of the instances, we can, all these drugs, which we have, estrogen suppressors, basically, aromatase inhibitors, leuprolide, they can all suppress, the ovaries, basically, and unless somebody has a specifically very high risk of developing ovarian cancer, like somebody having these BRCA mutations, there's no, oophorectomy is not necessary in majority of the patients.
Okay.
Any other advances in breast cancer apart from targeted therapy?
Well, lots of advances.
Do you feel in India every facility is available in breast cancer? Or
I think so. Yeah, I think so. But the investigation has to be very specific, basically, and it depends upon the stage of the disease. How far the tumor is gone. Generally, in early stages, stage 1, stage 2, when the tumor is small, basically, only 1 or 2 lymph nodes are involved. And typically, the key way to remember stage is basically stage 1 is when the tumor is less than 2 centimeters, stage 2 is between 2 and 5, and stage 3 is more than 5 centimeters. Basically, So early stage breast cancer, we do not need to do, MRIs and PET scans and things like that. But when we go to stage 3, when the tumor is quite large, or lymph nodes are matted, then we got to,
So I think I'll create a formula of 2. We don't have to remember formula stage 3. Formula of 2 is that less than 2 or more than 2 centimeters. If it is more than 2 centimeters, it is stage 2 or 3.
Correct.
Correct. That's all.
Yeah.
Let the specialist decide 2 or 3. But at least at the GP level, they must be able to say less than 2 centimeters, more than 2 centimeters.
More than 2 centimeters.
If it is more than 2 centimeters, patient immediately should be.
But for a GP, I believe even 2
Or even if the
centimeters
tumor is
would
fairly
be
large.
The day of diagnosis I'm talking
Yeah,
about.
even the tumor is fairly large, if the lump is
Yeah.
fairly large, this is at least stage 3 disease.
Okay, let's forget about breast cancer. Talk about a little bit on pain management. What's new in pain management? Because that's a new specialty coming in the country.
Correct.
And if Dr. Monga wants to start a pain management clinic, what should he do?
Okay. Now, pain management basically involves several modalities. Basically, typically as an oncologist, we do pain management, which does not involve invasive things, basically. But in pain management, one must first understand the pain, basically. Where is the pain? What is the intensity of the pain? Is this a chronic pain or an acute pain? It is an acute on chronic pain a lot of times. What happens? What is the type of the pain? Is it like a burning pain, like a neuropathic pain, basically? Is it a sharp, pain, dull pain, and all those things matter, basically. And then we got to investigate the cause of the pain, basically. Is it related to, say, for example, some destruction of the joint, or arthritis? In oncology and also in hematology, where I see a lot of sickle cell patients as well. We see a lot of joint destruction going on. So first we have to determine what is causing pain and what type of pain is it? Is it acute pain or chronic pain, basically, and then determine what to do about it. Now, suppose if it's a pain which is coming from a joint. Then what we do is normally we'll send the patient to one of the orthopedic doctors, and see. So painkillers should not be the first answer to all the pain.
Okay.
That is the take-home message.
That's great.
In fact, painkillers should be last resort for the pain.
Okay.
First you find out what's causing pain and what can be done besides providing the narcotics, basically.
Painkillers, this is obviously the painkillers are painkillers.
But again, now mind you, a lot of people have chronic pain, basically, because of destruction of their tissues, the destruction of their joints, basically. Now, in that case, if the patient has been to orthopedic physician, you have, removed, you have ruled the possibility of this being neuropathic pain, for which there are going to be different, anti-epileptic, drugs, gabapentin, and those kind of drugs, will be used. Then, if you are absolutely certain that this pain is a chronic pain, and this is being caused by destruction of the joint or destruction of other tissues, basically, then you've got to be bold enough to provide them the painkillers in the form of narcotic analgesics, basically. Now, for chronic pain, the best narcotic analgesic, is methadone. Methadone typically, in the United States we use for, people who are actually addicted to pain medications, like heroin addicts and those kind of people. But why do we use in those patients? Because methadone has a very, very long half-life, 55 hours, to be specific.
Okay.
So when they come off, when we take them off the heroin, basically, methadone is going to stay in their body and then accumulate in their body and will make a level in their body, through which, their withdrawal is not going to be able to penetrate. Same thing for chronic pain patients, It just builds like a cushion, does not allow pain to, go beyond a critical level. Where the
You're
patient
talking
will
about that
actually-
methadone, you can use it for non-cancer?
Yeah, sure, why not? Absolutely. I mean, these are recommendations of American Pain Society. Any chronic pain, in any chronic pain, we can use methadone. It's a great drug. It's very cheap, basically, and
How it is used? How it is used?
just oral, once or twice a day, basically.
The pain effect is also great.
Pain effect is very good.
Very.
Yeah, one thing very, very important about methadone basically is that unlike other drugs like morphine or hydromorphone, or pethidine, whatever is being used here, these drugs not only have all these are centrally acting drugs.
Mm-hmm.
So not only these drugs basically, they actually, so these drugs actually act by, by blocking the pain, the efferent pain fibers basically, but they can also stimulate sometimes the pain causing fibers as well, especially in higher dosages. So patients can have pain due to narcotics basically, what we call as hyperalgesia. This is hyperalgesic pain basically. Methadone doesn't do that. Methadone never stimulates the pain fibers, it only stimulates the fibers which are pain inhibiting fibers basically. The issue with methadone is that it can cause prolongation of QT interval. So a patient who is on methadone should have an EKG done every 3 months or so, 3 or 4 months basically, to make sure that the QT interval is still staying in a normal range. And then, of course, they should avoid drugs like erythromycin.
I want to interrupt because I myself in 35 years never used methadone. So therefore, just define it more.
Yes.
I mean
Now,
who
these
can
are
use
all
it, who can use
recommendations.
it, who cannot use it? Is it freely available? Is it under which scheduled drugs?
No, it's not really available. It's just like any other narcotic, basically.
It's a narcotic drug.
Yes,
so therefore
but-
it will require Schedule X. It will require multiple prescriptions.
It will
Who
require
is, who can give it? Anybody?
anybody can do it, or any physician who has knowledge of pain management.
And then how long it will continue?
For chronic pain, it has to be continued perhaps lifelong, because chronic pain is chronic pain. You have ruled out all the other aspects. You ruled out.
Versus tramadol and others.
Yeah. Now, those are more for acute pain, basically. The management of acute pain is very different. For there, you do not need these longer acting medications. Basically, they're plus also, even in chronic pain, everybody should use analgesics basically. Aspirin and other anti-inflammatory NSAIDs.
Methadone is to be given on what, alternate days, or you said 55 hours?
Well,
is the-
typically, because it's a very long half-life, it should not be given more than twice a day. Should be started at a very low dosage, basically, because, as I said, it's a very long half-life, and it's very potent, So if somebody, say, for example, is on morphine, they have to be converted to equal analgesic dose of methadone, before we start, giving them.
Is it addicting, or in any way you're giving it?
Well, all the drugs are, they call
Must be, I
stimulants.
believe, yes.
Now,
Mhm.
if somebody's in pain, basically, they are going to get dependent, on that, but we won't call this necessarily addiction. Addiction basically is to people, who are using it for recreational purposes, basically.
Mhm.
But yes, these drugs, can cause dependence, no question about it, and that's why one has to be very careful, basically, to make sure that you
don't misuse.
you don't only have a subjective but also an objective evidence. Basically, if somebody has avascular necrosis of the hips, basically, and they're practically walking on their bones, they got to have pain. Basically, So, but you got to have some kind of objective
Is it
evidence as
effective
well.
in pains in the abdomen also? I mean, the cancer of the any part of the
Absolutely.
liver, for example, or gallbladder.
Yeah, it is one of the most effective drugs for cancer pain as well, and we use it very frequently, and requires very small amount of dose basically, and as I said, generally doesn't cause much much tolerance, so we don't have to keep increasing the dose all along because of the long half-life. Patients generally get settled.
I still
on a small
feel, yeah, I don't agree with you. I still feel music is better than methadone. So, we have 10 minutes left only. Let's prove it.
No, I'm not prepared for that.
You need a good
I need a little water actually.
water, yes. Water, honey.
He says in Kapurthala, Punjab, methadone maintenance treatment is now available for drug users. And MMT program was launched in 2012 and in partnership with AIMS, and they basically are using it for drug dependence. While buprenorphine, another drug medication, is already available in India under the national methadone, with its demonstrated effectiveness, will add to the options available for treating opioid dependence. I'm only trying to say, is it in India passed or cleared by DCGI for which conditions? Methadone. That's the only thing.
I'm not sure which conditions cleared for, but it should certainly be cleared for chronic pain. And this is not me talking. I was recently
I mean, there is no
in
pain bigger than
the
cancer.
International Opioid Conference at Harvard, and it's very clear that methadone is the #1 drug for chronic pain, basically, right now, for all the reasons that I mentioned.
See, he's saying he doesn't know autism. You were saying he's very different.
Ask for a glass of water.
So is that a water
Indication
so
that
it's
he
a new treatment for singing?
Yeah.
Glass of water.
He is trying to clear his throat. And then
So, well, I was told
we
he
can
had to
offer
pay.
him. We can offer him a there was tea also for him. Which was started.
I don't know what. Are you serious about me singing?
Yes,
So why not? Yeah, why not?
Whole-
We'll again
whole-
listen to your
the whole,
tea.
the whole country is listening to you.
Yeah.
Okay, well, I will sing an old song from the
Live telecast.
Just a few.
That should be a good one.
मैं ये सोच कर उसके दर से उठा था कि वो रोक लेगी, मना लेगी मुझको। हवाओं में लहराता आता था दामन के दामन पकड़ कर बिठा लेगी मुझको। कदम ऐसे अंदाज से उठ रहे थे कि आवाज देकर मना लेगी मुझको। मगर उसने रोका न उसने बुलाया, न दामन ही पकड़ा, न मुझको बिठाया, न आवाज ही दी, न वापस बुलाया। मैं आहिस्ता आहिस्ता बढ़ता ही आया, यहाँ तक कि उससे जुदा हो गया मैं, यहाँ तक कि उससे जुदा हो गया मैं, जुदा हो गया मैं, जुदा हो गया मैं, जुदा हो गया मैं, जुदा हो गया.
Very good. Two more questions in between. He says vascular necrosis of head of femur is frequent if narcotics are not given under strict observation.
No. Narcotics typically, the only issue with narcotic basically is severe constipation and hypogonadism. Those are the issues with narcotics basically. People lose their sex drive and people get very constipated. But besides that, there's no evidence to suggest they have any effect on the bones.
Even constipation should be a big issue.
So we must, we must make sure that they're drinking enough water and they are taking some stool softener when we provide them with the narcotics.
So one compliment has come, excellent voice of the webcast and very melodious. This is for you.
Thank you.
That we already knew it, but let the whole India know it. That you were so good.
So we still have 7 minutes before we wind up. One more song.
Oh no.
You don't want it? Okay, fine. Doesn't
You
matter.
had
You can have
n
two.
number of songs.
You
to
can have
those
two.
years, He had n number of songs to his credit.
I was totally unprepared. I'll be happy to answer any questions. Are there any questions on breast
Yes,
cancer?
yes. Which song will heal a breast cancer woman?
Oh, very interesting question. It is a song which comes from the heart, basically.
Which
And
one?
everybody has
And it's song of love.
different song basically that just comes out of the heart. And the idea is to have faith. Idea is to know that this is not the end of the world, basically. And the idea is to just stay calm, and because that
Patient has
stress,
also to be receptive. She has
see,
to
stress
be
is going to cause the release of these catecholamines, steroids, and they are going to they
So
are.
give me a song which gives you endorphins. Listening to your song will increase the level of endorphins. Let's sing it.
Oh, wow. रोशन तुम्ही से दुनिया, रौनक तुम्ही जहाँ की, फूलों में पलने वाली, रानी हो गुलसिता की, सलामत रहो, सलामत रहो, रोशन तुम्ही से दुनिया, रौनक तुम्ही जहाँ की, फूलों में पलने वाली, रानी हो गुलसिता की, सलामत रहो, सलामत रहो, सलामत रहो, सलामत रहो.
great, very good.
So time to wind up again. You can see we have recorded it. This will be on our IMA website and eMedix's website. You can watch this program right from now again as many times as you want. And we have also put down a commentary before that which says lung cancer now has an effective targeted drug therapy, and 1 lakh breast cancer are diagnosed each year, 3 lakh diagnosed in US, 83% of breast cancers are now cured, and we are not talking about 5-year survival rate. Smoking, pollution, high-fat diet may be the answers. Urbanization is a factor as far as breast cancer is concerned. And then we talk about BRCA1 and BRCA mutations, genetic factors, ovarian cancers. Then we have talked about that breast cancer, people have more chances of ovarian cancers. And we say strong family history, early age cancer test for mutations if possible. Before going for anything, go for genetic counseling. And screening starts at age 20, self-breast examination, and then every year examination by a physician. First mammogram at age 30, and if there is a family history, otherwise at age 40. Smoking is linked with lung cancer as well as cancer of the breast. Cancer of the breast is also linked with drinking. Any amount of drinking is not safe for women. Even small amount of alcohol can cause cancer. In Sweden, lots of people eat fat, and that's linked to breast cancer there. And we have lots of markers CA 27 to 29, CEA, but they are not for screening. Alcohol is not linked to ovarian cancer, and then breast cancer, people have twice the risk of getting ovarian cancer. Alcohol can cause more than 38 types of cancer. Up to 1% of the cancers, breast cancers are in males. Prevention is possible. Walking is the best answer. If lump is mobile, if the breast has a lump which is mobile, small size, less than 30 years of age, you can watch. But if the breast cancer is big enough, follow the formula of 2, more than 2 centimeter, need urgent referral. If you are suspecting any breast cancer, and if the mammogram is suspicious, always go for a core biopsy and look for whether the cancer is ductal or lobule. And if it is ductal or lobule, is it invasive or non-invasive? The treatments may be different. Remember, breast conservation surgery may not be possible in every situation. In some situations, it may be possible. It may be possible surgery with radiotherapy, or in some cases, you may require a surgery with radiation as well as chemotherapy. Sentinel node biopsy is a must, and if the sentinel, and along with that, you may have to go for a sentinel node biopsy, and then you need to go for estrogen progesterone receptors to decide whether you need to give a tamoxifen later or not. And of course, you have NCNN guidelines. You can go on the website and see and whether you're following those guidelines or not. And in narcotics, we have basically narcotic pain management. We have basically talked about methadone, that it is one should look for evaluation, and methadone can be given lifelong and it's safe. That's what we have talked about. And
it does cause QT prolongation. So
it does cause a QT prolongation. So
So
involve
why
people like me.
does-
So when you are talking to people like Sajeev, you also need to talk to people like us who are cardiologists who should look after the QT prolongation so that it doesn't occur. So before I ask Monga to wind up, and that's time for me to say thank you to Sajeev, and we have seen his melodious voice, which will be recorded forever in our digital IMA webcast. And next week we will have his wife Reshma, who will be with us in a webcast, and where they will be talking about the concept of wellness and lifestyle, and at the same time we'll meet.
So KK, we have gone a long way. I mean, since we graduated 40 years back, I think any lump in the breast, radical mastectomy was the only solution, and a little bit of radiotherapy, but we have come a long way. Thank you, Dr. Sajeev. You have been our very old friend also, and you have come to India and we have troubled you. Thank you very much for
my pleasure.
enlightening all our friends today on this live telecast. And KK, as usual, is a good moderator. He has a good knowledge also, so he knows where to mold the things and where to reach. What is the target in the
And
mind?
how to accept the songs.
Yes.
That's all for today. We'll come back next
Thank you
week,
very much.
next Thursday with another episode. Till that, goodbye. Thank you.
Thank you very much. Bye-bye.